Welcome back to the MedEdit podcast, your go-to space for evidence-based medical education.
And the only podcast where two board-certified physicians clarify medical misinformation.
Today, we're talking about something that doesn't get talked about enough despite how common it is: chronic kidney disease, also known as CKD. It's a serious condition that affects roughly 1 in 7 adults in the United States, but most people don't even know that they have it until the later stages. To guide us through this, we have the perfect guest. Dr. Ashley Garcia-Everett, a board-certified nephrologist, associate professor at UT Health San Antonio, and medical director at one of University Hospital's dialysis centers.
We really wanted to shed light on what causes CKD, how it's detected, and most importantly, what we can do to prevent it. And later on in the episode, Dr. Garcia-Everett will talk to us about a disease called Polycystic Kidney Disease, a disease that affects about 1 in every 500, 1,000 people worldwide, and is actually one of the most common inherited kidney disorders.
Thank you for tuning in to the MedEdit podcast. Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the MedEdit podcast.
Before we dive into the information, we wanted to welcome Dr. Ashley Garcia-Everett to the podcast. We are so happy to have you here.
Hi, thanks for having me.
So let's start from the very beginning. Ashley, for people who may not have actually heard the term chronic kidney disease and don't really know what it means, tell us, what is CKD?
So kidneys are the primary organ that's filtering your blood. So chronic kidney disease happens when the kidneys are not filtering quite like we'd like them to. There are, and I think that staging of chronic kidney disease, and I think we'll talk about that a little later, can be a little confusing because most people have CKD stage 3 by the time they see a kidney doctor. And so they say, what happens to stage 1 and 2? Well, usually that's pretty normal kidney function, but something else is going on, something more apparent, blood in the urine. They're having kidney cysts or kidney stones or something of that sort. So it can be a little confusing the way we stage it as well. But essentially, chronic kidney disease is when the kidneys are not filtering like normal, or there's something else really apparent that's wrong with them.
Yeah. And, really, it's like you mentioned, since it's kind of delayed, usually when you see somebody, it's not something that happens overnight.
No, absolutely. So now there are cases, and this is the unusual case, is that something happens really acutely. So like say we have a lupus patient and all of a sudden their kidneys start getting attacked by their antibodies. That can happen, but that's not the common scenario. The common scenario is that somebody's had something going on for a long time, and it gets eventually recognized, unfortunately, like you mentioned, usually pretty late. So this is typically something that's going on for a long time before it gets recognized.
And so you mentioned like kidney function cutoffs, right? Talking about lab work, things like that. How is CKD staged based on like their function? How do we know if it's your kidneys are functioning well? If someone comes in and for their just annual wellness visit and, they may hear something from somebody like me that says, oh, we've seen a little bit of a change in the trend. We may want to repeat it again later. Most of the time us in like primary care, we're trying not to terrify our patients and be like, this is probably either transitional or it's not a super big concern, but it is something to keep monitoring. What are, explain what we're looking at when we're talking about these stages.
Yeah, so CKD staging, like I said, it's a little confusing, but what it is basically we check a lab called creatinine. Creatinine is something that appears in your blood because it's a waste product. Kidneys get rid of it. And so normally for most people, that level is usually less than 1. There's a little bit variability with labs, but we use that number and then we put it into a calculator. Now that calculator gets us something that's a really complex concept, but it's something called a GFR, and you'll see that reported often on labs. And actually we call it an eGFR, an estimated glomerular filtration rate. And the glomerular filtration rate oftentimes gets discussed like it's a percent, but it's not actually a percent. What it is just a description of how fast the kidneys are cleaning the blood. And so a young, really healthy person will actually have a number that's greater than 120 typically, or around 120. More than 90 is totally stone cold normal. But it's when it starts to decrease beyond that we kind of get these CKD stages. So we stage 1 through 5. And again, the confusing thing is most people don't see a nephrologist till they're stage 3, because above 60, those equations that we use, they're just equations. They're not perfect. And so above 60, they're not very accurate at telling you what your actual GFR level is. So above 60, which is stage 1 and 2, you've got to have something else. kidney cysts, blood in the urine, something else, a biopsy that says that something's abnormal, something else to say that's chronic kidney disease. Below 60 is when we start to diagnose stage 3, 4, and 5. And those go, stage 3 is that 30 to 59 range, and then stage 4 is the 29 to 15 range, and stage 5 is below that. And we really don't like to look at one single number. We kind of need to know over time. And that number, what concept you said, like, what's the trend? That is the absolute most important thing. And sometimes people will really get into a panic because, oh, my GFR dropped. It went from 48 to 45. Well, there's going to be a variability every day. I'll tell patients that sometimes we have somebody will order 2 different lab tests and both of them have creatinine in it, and they get drawn at the exact same time, and we get slightly different numbers, which gives you a slightly different GFR. So, the overall trend is, I think, the most important thing.
Yeah. And I think that's really important to emphasize what you were saying, is that most people don't actually have any idea their kidneys are struggling at all until they're way well into that pathway of deterioration.
Yeah, so we often look, so for us as kidney doctors, we're usually not just looking at the blood, but we think the urine is just as important because it'll often give us those early clues about, is there something abnormal that it shouldn't be? And most commonly we're looking at, is there blood in the urine that shouldn't be there? And there shouldn't really be any blood. Is there protein in the urine that shouldn't be there? So those would kind of give us those early clues to, hey, maybe kidneys have a phenomenal ability to compensate even when things go wrong. So sometimes what we'll see is damage before their actual function is affected.
So let's talk about what leads to CKD. What are the main causes of it? So if we see this trend is changing, what can we link together that might be a cause for it?
Most commonly in the U.S., far and away, it's diabetes and high blood pressure. And worldwide, there's a disease called IgA nephropathy, which is an abnormal antibody, an IgA antibody in the body that affects the kidneys. That just happens spontaneously for most people. Can run in families, but tends to happen spontaneously. But that's worldwide. Far and away the U.S., it's diabetes and high blood pressure, unfortunately.
Yeah.
And then, of course, like I mentioned, that you can have things like lupus or other what we call glomerulonephritis, which just means inflammation within the functional units of the kidneys. Lots of other things can cause that, usually a lot of autoimmune syndromes. So people who have even like rheumatoid arthritis can get kidney disease over time, or Sjogren's. Ankylosing is very common, or not common, but a very common thing we as kidney doctors see, which is another antibody that attacks blood vessels.
Yeah. And just because since it is so common, I think people think we're exaggerating a lot of times when we talk about the kidney function relation to diabetes and hypertension. So what's going on with the kidneys when you have diabetes and high blood pressure that's causing them to decline?
So we know that, diabetes affects big blood vessels, but it also affects small blood vessels like we see in the kidneys. So within the kidneys, there are, like we call them, lots of millions of little factories called nephrons. And those are all little individual units that actually clean the blood and make urine. And the most important part of that is something called the glomeruli, which basically has provides blood flow, that blood can be cleaned and then urine can be produced from it. And so each of those little factories, all those little blood vessels, over time, when people are diabetic and it's not well controlled, what we see is damage to those blood vessels. And so oftentimes in diabetes, the first sign that we're seeing is not kidney function gets worse. What we see is that damage, and how we'll see that clinically is we see protein in the urine, or something called albumin as well. Albumin is just a type of protein. And so what we test for routinely in diabetics is, are we seeing protein or albumin in the urine? Are those early warning signs there that, hey, kidneys are getting affected by diabetes, before we start to see that decline? Because we want to do something early.
So are there any other risk factors people should know about besides, yes, they may have diabetes or high blood pressure, but anything else, maybe even modifiable or not modifiable factors they need to know about?
Yeah, so definitely. So family history is really important. And although diabetes is not strictly like an inherited disease, we know that if you have a first degree family member who's required dialysis, your risk for needing dialysis is much higher. So that's an important,
Mm.
important piece of history that we like to know. Um, Obesity, 100%, even independent of diabetes. So people often think obesity, my numbers look good, I'm fine. We see obesity affecting the kidneys, just independent of diabetes status. And then also, if you add that to diabetes, can also worsen the progression of kidney disease. Smoking. I don't think there's anything good about smoking. And it's like, if you ask every
Ulcerative
specialist,
colitis, maybe?
That is the one like tip that anyone ever said.
I know. I always have to like counsel people to quit smoking, and the UC patients are like, but do I?
That's funny. That's funny. So we all, like, every specialist has their issue with smoking, and mine is, it actually can make the kidneys worse. So smoking is a big thing. Heart and kidneys are super related. So any heart disease can also affect the kidney disease. Heart disease itself can actually cause kidney disease. So super interrelated. And then the biggest thing that people, I think, are not aware of is that over-the-counter medications, like in what we call NSAIDs, non-steroidal anti-inflammatory drugs. So ibuprofen, Aleve, Motrin, any version of those, especially if they're used chronically and in higher doses, can cause kidney failure. Again, independent of diabetes and high blood pressure, but can make that situation much worse. And so, I think the problem is they're over the counter. And we all know them and we all use them. And so people think that they're safe, but they're intended really for short-term use, especially without supervision of a physician. So it's when the people start to use them long term, or we're trying to avoid opioids, which is very understandable in today's, given our history of that in the country. So very understandable. But we see a lot of chronic kidney disease. So the lower dose that you can use, the less frequency, don't use it long term because those absolutely will make kidney function worse over time. That medication in combination with a very common blood pressure medicine, things that we call them ACE inhibitors, lisinopril, enalapril, ramipril, things like that. NSAIDs plus those medications, especially if you're sick, we see a lot of acute kidney injury with that. So you have to be really careful with them.
And I assume age somewhat factors into this, like, somewhat the chronic medical conditions and then maybe somewhat age.
Oh, yeah. So we know that there is some degree of age-related decline in kidney function for sure. But age-related decline doesn't, while it might decrease your GFR or how fast you're filtering, doesn't lead to kidney failure requiring dialysis independently. But certainly the longer you live, if you're losing some function and then you're losing from age and you're losing some function from diabetes and you're losing some function from NSAIDs, everything can add up. And it can cause things to be worse over time.
So the takeaway here is if you have diabetes, high blood pressure, or family history, you should be especially proactive. Make sure that your primary care doctor or whoever you're following regularly is aware of these histories as well, both in you and your family. I don't think we're going to touch on it later, so I wanted to bring it up now. But I do have patients that come in often, and we see these isolated elevations in like their creatinine levels, and they are taking a lot of creatine supplements. So can you tell me a little bit more about the role that, creatinine and creatine and the kidney function, all that play with each other, whether it's something that we need to counsel our patients more about, especially because we've talked in previous episodes about creatine and studies showing relation to brain health. And then, of course, you have all your people who try to use it for, exercise, musculoskeletal purposes. So give me the nephrologist take.
So I don't, creatine itself, I don't think is, as far as I'm aware, not toxic to the kidneys. It depends. Everything is dose dependent though, right?
Sure.
So
right.
like, could you potentially take so much that it could be, sure, you could probably do that with just about anything. I mean, Tylenol, we generally say is safe for the kidneys, but Tylenol can actually, in large, excessive chronic use amounts, actually cause kidney injury too. So I think you have to always be cautious and be careful about the amount that we're talking about. But let's say in like, a reasonable supplement, like for an additional protein, probably for the most part, okay. Might it increase your creatinine a little bit? Possibly, probably more due to if you do gain muscle mass. because creatinine comes from muscles. And so, if you load up the system a little bit more, even if we're filtering well and taking a percentage out, we may not get down to the lowest level when we had a lower muscle mass. So that's one thing. And high protein meals even can increase creatinine in the blood. So, but not to extremes. We're talking about slight changes and slight increases. The biggest thing I would say with creatine and all these other supplements and whatnot is that they are large protein loads. And while protein is not necessarily, again, in normal amounts harmful for the kidneys, in excessive amounts, there are concerns. And certainly if you can't process that normal level of protein, you're going to actually lose it as urea in the urine.
Yep.
And that can actually dehydrate you over time. And oftentimes that people who, that bodybuild and do lots of weights and lots of supplements find that they urinate more and they might be thirstier more and they drink a lot more. And that's appropriate because their body's trying to get rid of all of these things that they can't actually utilize. And you need to do that in urine. So if they're not balancing that correctly, there is a risk of like dehydration with that. So that's something we never want.
Yeah.
Here in South Texas, I think that's so much easier to do too.
And I think from a nutrition standpoint, a lot of people don't realize like you really only can absorb so much in one meal
Right.
of protein.
Mhm.
Like I see these recipes sometimes and people will be like, it's got 100 grams of protein per serving. You're like, you're going to absorb that. Like
Mhm.
there's no
More
way
than
that
you
you're
need in a whole day.
Yeah, exactly. Like literally. And so you're going to have to pass it out somewhere, but like you don't need that. Like you cannot absorb that much protein in one setting. Like you physically can't. So whether you're trying to reach your goal of 100, but you do it in one meal ain't going to work. So
Mhm.
I think in general, that's probably where we do see that where people do too much at one time.
Mhm.
And also to help with that confusion, so we more routinely are using another blood test called cystatin C to help us as another way to calculate GFR if there's some maybe confounders, like somebody's, like you're saying, taking creatine, wondering, is that affecting my levels in my blood, or is that affecting my GFR calculation? You could also check something called cystatin C. It's send out, even for us, it's a send out. For most centers, it's a send out still. And so it takes a little bit longer to come back, but it's another way to kind of get a perspective on it, like really where's the kidney function probably at. And I guess that's the important thing, is that all of these are estimations.
Yeah.
We're not doing
Right.
direct measurements of kidney function.
Yeah. And we've kind of talked about how sometimes there's a lack thereof, but if we're going to have symptoms potentially of chronic kidney disease, what kind of symptoms could people look for?
Yeah, so like I said, most people don't get to me, unfortunately, until they're stage 3. But even then, they are far and away usually asymptomatic. And I'll tell you, I always ask my patients, do you know why you're here today? And very frequently the answer is no. No idea, because they feel fine. And I'm glad they feel fine. And I think we have to be grateful for, as common as chronic kidney disease, that fortunately there's not a ton of symptoms early on.
Yeah.
Usually it's not till stage 4 and the GFR drops below 30 that we start to see some symptoms. And the most common things are that you can start to have more fluid retention, so swelling in the legs. Sometimes people start getting anemia at that stage. And then they might feel, fatigued or a little more tired from the anemia itself. If you have protein in the urine in your disease, like diabetic kidney disease, which causes protein in the urine, they might see foamy urine. Or there can be other diseases that cause a ton of protein in the urine, not related to diabetes. You might see something like foamy urine. I usually tell people, does it look like you can wash your hands in those bubbles? As they advance more to stage 5, which is that GFR below 15, that's when we start to see much more symptoms. We look for nausea, vomiting, and often not just like here and there, like persistent. Are you losing weight? Does food have flavor? So we describe a funny medical term as dysgeusia. So that's this metallic taste in the mouth that they can get. But not everybody says it's metallic. Some people describe ammonia. Some people describe just a funny taste, or nothing has any flavor anymore. So it can be lots of different presentations. And electrolyte abnormalities that we worry about, again, usually are not symptomatic until they're really severe and life-threatening. So we just tell patients when they have a low kidney function or they're getting towards dialysis, that if you don't feel well, just go get checked out. Because a lot of these electrolyte abnormalities, we just don't know. If your acid levels are high, your potassium is high, we just don't know till we check, because the symptoms are so nonspecific.
Right. The symptoms could be easily mistaken for just about anything else. So it
Right.
is, I think that's when patients come in, they have non-specific symptoms and we check labs. We're always checking kidney function, right?
Yeah.
We're always looking because that
Right.
could be basically presenting as anything. And so screening is so critical for that purpose.
Yeah, exactly. Especially if you have the high risk history, like you were talking about, or high risk diseases like diabetes and hypertension. And so we know it's kind of how you're going to check for it. Say that your PCP or you diagnose someone with CKD, what can they kind of expect once they get to you for that like CKD, like long-term prognosis or progression, or basically what to expect?
So usually what we're focusing on is, what's the underlying cause? Number one is that number 1, 2, and 3 is what is the underlying cause and how do we address that? If it's diabetes and high blood pressure, those have to be addressed and well controlled to stow, because we know we can't cure those diseases. We can't stop it completely, but we really can put the brakes on quite a bit for these. So the biggest thing we're looking at is what has been the trend over the last couple of years? How fast is everything getting worse? What's the protein level again in the urine? I mean, the protein is so important to us because that really tells us what that risk is. Even for people who are at earlier stage of kidney disease, if their protein level in the urine is very high, they are still in this very high risk category. And so it's super important for us to know that. So then it's kind of optimizing medications, or is there an underlying kidney disease again? Like lupus or vasculitis or something else that we can address that specifically. And in those cases, we often can do, if we can get them into remission, can do a lot for them. The diabetic and hypertensive tend to be a little harder to really just stop it where it is. But fortunately, we've had a lot of great medications come out in the last year. So over the last 20, 30 years, all we had was ACE inhibitors, angiotensin receptor blockers, like we call them prils, or they end in ardin, lisinopril, losartan, just for blood pressure management, reduce the protein. But in the last several years, we really found that these, we call them SGLT2 inhibitors. These medications like brand name Jardiance, empagliflozin, or Farxiga, dapagliflozin, really seem to, not only they're diabetic medications, so they help with the diabetes, but apart from that, really reduce protein levels in the urine and delay the progression of chronic kidney disease. So they originally were studied for diabetes indications, diabetic kidney disease, but we really expanded that to any partner kidney disease. So any kidney disease that has protein in the urine, they do seem to be beneficial. And you're kind of seeing them everywhere. They're good for heart disease, good for chronic kidney disease, good for diabetes. They help a little bit with blood pressure too. So we've been very excited to see how much impact that those medications have. In the last couple of years, another medication called Corindia or finerenone, also similarly beneficial for heart and kidneys. I've really had some great success in patients reducing protein levels in the urine with that additional medication. But they are new medications, so they can be a little pricey. That's always a little bit of a barrier we have to worry about. And even now, everybody's talking about GLP-1s. So Ozempic and Mounjaro and whatnot. And there was a study that came out last year that Ozempic in chronic kidney disease also reduces protein in the urine and delays progression. So I think we'll be seeing that as more data comes out, more widely used in our patients. Kidney patients are always asking me, how do you feel about those drugs? And, we talked about diabetes as a risk factor, obesity as a risk factor for chronic kidney disease, and you've got a drug that addresses two of those really hard things to address. I'm a big fan. I think that they're great medications.
Just because we've mentioned it, and some people may not know what that is actually, but can you describe what dialysis is? Just, and we talked about how it's usually like your stage 5, but for some people, they may have never seen somebody do dialysis, or, not be familiar with what we're actually doing when we dialyze somebody.
Yeah. So dialysis is like this big scary thing that nobody ever wants to get to, right? And we don't want it, but it's available, and it is, when I got into nephrology, it was one of the things I felt like, it's like the only organ that we have that we can actually replace with a machine. So it's pretty incredible. It's incredible doing it for, gosh, what is it now? 70 years or something like that. It's amazing.
Yeah, a long time. It's crazy.
So basically, dialysis replaces the kidney function when the kidney function isn't enough to continue to sustain life. So, which also means that we don't just do it because we want to do it. We do it because we feel like somebody is at so high risk that they're at risk of significant, mortality or of dying, basically. Without it, or significant complications that could in the hospital and very, very sick. So we don't want that. So when we make that decision to put somebody on dialysis, it's almost always somebody who's stage 5 or below. I mean, stage 5 with the GFR of 15 or below. And most people, in my experience, don't need dialysis till they're less than 10. So you certainly don't hit stage 5 and then, okay, it's dialysis time. It's when basically there's an indication. So there's something electrolyte wise. So something we can't control with medications. There's something about there's fluid retention and we can't control it with medications. Or there might be, unfortunately, for the toxin buildup in kidney disease, we don't have any medications for that. So when the toxin buildup gets so bad that, they have nausea, vomiting, they're losing weight, and or they're confused, that's a big red flag. That's immediate dialysis. Or they get inflammation around the heart because of the toxin buildup. That's an immediate dialysis. So if there's something medically that we can still manage, we'll still manage it medically. But if it's beyond that, then it's time for dialysis. And like I said, most people don't need it to the GFR is less than 10, but we usually like to start planning for it when we see that things are heading that direction, when the GFR starts to get below 20. And what it is, most common dialysis in the U.S. is hemodialysis, so blood dialysis. In most common scenarios, you're going into a clinic 3 times a week for 4 hours each time. And basically the machine is cleaning their blood for you. And it happens throughout the session. It's only 12 hours of cleaning, though, so it really does not replace what your native kidney function is, or you come anywhere close to it. But it's enough to continue to allow you to live and to get into a better spot. There's other types of dialysis, like the same blood one. You can do a version at home, which is great for some people who are a little more independent. There's also a belly dialysis called peritoneal dialysis, where we basically, instead of using the machine to filter, you actually use your own body lining to filter. You still have a machine that you're connected to that basically puts fluid in the belly and removes it periodically, and that happens most commonly overnight. That type of dialysis is great if you want to maintain independence, but you do have to be more independent to do it, to be able to manage it at home on your own. But there are different options available. And then, of course, we put into the same category as what we call renal replacement therapy, that our number 1, 2, and 3 choice is transplant, if we can, if somebody's eligible. So hopefully before you get to dialysis, you become a candidate for transplant when your GFR levels fall below 20. Or even after you start dialysis, that process can start. But we're always advocating for transplant first if you're a candidate. Dialysis is your backup option. And then even beyond that, a living donor transplant. So if you have a family or friend or anybody, sometimes there's altruistic donors who's willing to donate a kidney. Those living kidney last so much longer than what we call deceased donor kidneys, meaning somebody passes away and donates it. And can be scheduled and timed and done before we need dialysis.
So we talked about what it is, symptoms you may have, treatments we have for it. But if you had 5 tips that you could give our listeners on how to protect their kidney so they'd never have to see you or a nephrologist in clinic if they have a choice, what tips would you give them?
So number 1 would be, if you have any chronic diseases, again, diabetes, high blood pressure, make sure that we're doing as much as possible to get those under control. Number 2, I think, would be if you are using NSAIDs, ibuprofen, Aleve, Motrin, Advil, all of those routinely for long periods of time, try to make sure at least you're monitoring your kidney function, but if you can, come off of them. I would say the next thing would be obesity management. So, and you could really put that into the other, what I was saying, in diabetes, hypertension. Obesity should probably be the third one in there. That if you are obese, that trying to get your weight to what's considered a more normal BMI was going to reduce your risk. And then I would say after that, and I hate to number these because they're not really numbered. These are all do all of these things.
Right.
Low salt.
All good tips.
Yep, low salt would be another thing. We eat a tremendous amount of salt in this country. It is in all of our food. Anything that's prepared, it's a preservative, finds its way into absolutely everything. So maintaining a low salt diet really is only possible if you're cooking at home. If you're not cooking at home, it's really, really difficult to achieve that. So the more fresh food, the more you can prepare at home. We always advocate for a more plant-based diet too, because not that the protein is harmful, but we know that a low salt, high potassium diet is beneficial for kidneys, and that potassium comes from plants. So fruits and veggies. There are no good and bad fruits and veggies. There's only different nutrients you get from each of them. So a variety of them. And then, we talk about if you have advanced chronic kidney disease, you do have to limit things like phosphorus and potassium, but that's usually when you're, again, stage 4 or 5. Before then, it's unusual to have to restrict those. And, especially potassium. I hate for people, early kidney disease patients to think they need to limit potassium, because most of the time when you look up what has high potassium, we're talking fruits and veggies, and those are so important. And kind of going along with all of that is, we're seeing this in every specialty, especially GI, like limiting processed foods. And again, there's probably lots of reasons for that. For me, also, it's easy salt. They all have salt. So limiting those, but probably for overall health, that's one of the best things you can do.
All right, it's time for one of our favorite games on this podcast, which we usually call myths or fact or myth busting, basically. So are you ready?
Yeah, let's do it.
Okay, let's do it. All right. So myth 1, if you just drink lots of water, your kidneys will be fine.
So generally speaking, water, that is one of the biggest things we hear as well, that I drink plenty of water. Water does not actually improve kidney function, nor does it generally hurt kidney function to not drink enough water. There are extremes to both of those, right? But kidneys have an amazing ability to dilute and concentrate urine. So when you see darker urine, you are drinking less water, so you need to get rid of less. And if you have dilute urine, it's because you're drinking plenty of water and you can get rid of more. So generally speaking, no. There are only 2 real diseases that we think about that really you do need to drink a lot of water. And that's if you have kidney stones and if you have polycystic kidney disease. Those are probably the only 2 scenarios. Otherwise, we say drink to your thirst. If you have chronic kidney disease, you might need to be cautious with drinking too much. Again, usually stage 4 and 5. Most other stages are fine. But absolutely, you can have issues with excess water. Most people will get enough fluid because we're talking water, but it can be any type of fluid that you receive throughout the day. However, having said that, most people probably don't drink enough water because we drink a lot of sodas, a lot of flavored drinks, right? And like really plain water is the best option as I drink my Fresca.
Yeah, I know. Well, I think it's crazy though too, because like I feel like I need personally a ton of water, or like I feel it in my body, and then I feel like my husband never drinks water and seems to function just fine. So I mean, whether or not his kidneys are taking a hit or not, but it's like I can't function if I don't drink water.
Yeah, but
like,
I mean, and usually kidneys will be fine. But you might feel other symptoms. You might have a headache. You might like not feel great, and that while it's not necessarily hurting your kidneys per se at that time, like still if you're not feeling good, you might need to try drinking a little more fluids. I think we do all I tend to be really bad about not drinking enough, and I have to remind myself. And the other aspect of it is, I think that there is a component that some people kind of get those wires crossed. Am I hungry or am I thirsty?
Sure.
And so like the idea of like try drinking a glass of water, maybe you weren't really hungry. I definitely happens to me all the time. Is that there could be a diet component of it to make sure we're not, overeating if we're really thirsty.
Yeah, no, that's probably true. It's probably me also drinking as much because again, if you are trying to like lose weight at all, like you're hungry, you're like, well, I'll just drink something and hopefully that signal will go away. I'm not hungry anymore. Alrighty, let's do myth number 2. So only older people will get kidney disease.
That's false. So anybody, again, you can have inflammation in the kidneys that can occur at any time in your life. And even we see kidney disease in kids, unfortunately. Now, they don't have diabetic kidney disease, which is the most common type that we see in the U.S., And then your risk of diabetic kidney disease does go up as you get older because you've had diabetes for longer. So we usually say after 10 years, probably you have some effects in the kidneys if you've had diabetes for more than 10 years. So there is some, like, as you get older, you've had those diseases for longer, but it's not just a disease of older people. Absolutely, we see it younger, unfortunately.
Yeah. No, I think that's very true because, like, again, especially for men, a lot of times since they are not like us, where they are in constant contact with healthcare from a young age because we see OB-GYNs and such from a fairly young age. I think a lot of men, especially, don't get things like that checked, and they'll be like what we would consider middle age, not even like older, before they actually start getting these things checked, and they've got like a decade of bad habits
Exactly.
that have caused damage already. Whereas we tend to have exposure to healthcare much earlier as women. So, all right, myth number 3, you will always know if there's something wrong with your kidneys.
Absolutely false. It's like they say blood pressure silent killer. Kidneys can be exactly the same thing. Again, usually not symptomatic until your GFR levels are really very decreased. So in the vast majority of patients are going to be stage 3, and they're not going to have any symptoms at all. So super important to get that routine screening with blood work, and then urine is indicated based on your risks. But at least usually blood work at least annually to get an idea of where you are.
Yeah. All right. And this last myth is because of something that I saw on TikTok, which after researching it, my algorithm is completely crazy now on what it's ads I'm getting on this. So, and actually most of them are in Spanish, which makes it really hard. But anyway, so myth 4 is I saw on TikTok that you can drink a quote kidney tea, end quote, and you can prevent kidney disease or even reverse kidney damage.
Yep. So I very much wish it was as easy as drinking a tea, but no, that's not true. There's no teas or any kind of medication, like one single thing that you can take that's going to reverse or cure your kidney disease, unfortunately. And the thing I really worry about is we have no idea what's in a lot of those things. And there are supplements, and herbs that can be harmful to the kidneys, and we have to really be careful with that. So
just like the liver.
And the thing is, I know there can be skepticism about prescription drugs and the less that we can do, the better too. We usually try to consolidate things as much as possible, but those teas are not free. And there's not a pay when you're cured kind of option. So I always say have a healthy dose of skepticism when anybody promises you oceanfront property in Arizona.
Sure. Well, and we've actually said this before too on this podcast, that it's a lot with these supplements and things like that. And not that any of us are against in general this industry, but if there was money to be made on something easy like this, a pharmaceutical company would have been looking into it. Like 100%. If there was something easy where they could manufacture and sell a tea that prevented or reverse, they would be doing it 100%. 100%.
And then making a prescription so that insurance will pay for it. So
absolutely. So it's not like any of us are against these, and there's, some scenarios where we do think it's beneficial, but like why we're so skeptical is because we know, like in general, when there's money to be made, like just interesting things come up. But one thing we do know about a lot of these companies is that they would be on it if there was, because they're not going to lose out on an opportunity to do that. So just a healthy dose of skepticism is always good.
Yep, absolutely. I mean, that's the whole, the Gila monster saliva, finding that, it's not that we don't use things from nature and that became data, that absolutely where we can generate from nature where things might be effective, but they have to be shown to be effective.
Yeah. I mean, even aspirin, you know what I mean? Like that's also, from bark or whatever, that comes from nature when they originally started realizing there was a benefit on chewing on these things, and we figured out how to isolate it, manufacture it, and sell it. So that's what they would do if any of these things had a lot of evidence behind them, for sure. So all right, well, that was a fun game. Thank you for playing misinformation or misinfact with me. But we're going to shift gears for a minute, and we're going to talk about polycystic kidney disease, or PKD, which is what we'll call it for simplicity. And I know this is a cause that's very near and dear to you and your family, as it affects your son and our dear friend, CJ. So tell us exactly, what is polycystic kidney disease?
Yeah, so the most common type that we're talking about is the adult version of polycystic kidney disease, where basically the kidneys start to form tons of cysts. And the usual description description on ultrasound is like innumerable cysts. There's so many you can't even count them. We're not talking one or two. And so what happens is about for 15% of the kidney, that these cysts start to grow and enlarge and start to compress on healthy kidney tissue and cause kidney damage over time. And it does affect both kidneys. Is the classic form of this is both kidneys are equally affected and they both are full of cysts. There's a childhood form that's a little bit different. Doesn't have so pronounced the amount of cysts. There are cysts, but they're usually what we call microcysts. They're very, very, very small. And that disease is very different. But classic autosomal dominant polycystic kidney disease or adult polycystic kidney disease. I mean, these kidneys go from like your normal kidney size, probably about the size of your fist, to massive, can be football sized. And both of them get really, really big over time.
Yeah, I think the other like kind of misnomer with it is that it's not just a disease of the kidneys, despite us calling it that.
Yeah, absolutely. So the main manifestation and the main symptom thing we see is how it affects the kidneys. But there are risks to other organ systems. So it more in that, so we do see liver cysts with autosomal dominant polycystic kidney disease or the adult form. Usually liver function is not affected. Usually liver function is actually really very good. But it helps us make that diagnosis. We often see pancreatic cysts too. The thing that we worry the most about with the autosomal dominant polycystic kidney disease outside of the kidneys is that you can have aneurysms in your brain. And those can rupture and are a significant cause of death in these patients. So if you have PKD, you have a family history of PKD, and somebody in your family has had an aneurysm, those are the patients that are highest risk and that we worry most about. Now,
Interesting.
The childhood form, the autosomal recessive polycystic kidney disease, is different in that it's the liver is always affected in autosomal recessive polycystic kidney disease. So it's not that the cysts actually cause problems. It's because they have something called congenital hepatic fibrosis. So their liver and their bile systems don't develop normally. And it's to varying degrees. Some kids will still have pretty normal pretty normal liver function and never need a liver transplant. Some kids will have significantly impaired liver function. More commonly, they'll have what we call a lot of portal hypertension. And so they'll get effects from the high pressures in the livers. And that can lead to a need for a liver transplant. So the liver part in the childhood form, the autosomal recessive form, always goes with the kidney disease. It's always both there. For the adult part, we tend to worry not so much about the liver, tend to worry a little bit more about brain aneurysm there.
Interesting. So, and obviously, because you mentioned about it being what you see more commonly for the autosomal dominant or adult form, so there is a chance of passing that on to your children. It is a genetic disease.
Yeah, absolutely. So different patterns of inheritance, different diseases, related but different. So autosomal dominant polycystic kidney disease, it is you have to have one bad copy of the PKD1 or PKD2 gene. So you only need one bad copy. And so you have a 50% chance if your parent has it of inheriting that bad copy, and that's all you need to have the disease. Autosomal recessive polykidney disease, it's a recessive disease, kind of like cystic fibrosis, where your parents, their parents are carriers. And, for the two genes, they have one bad gene, but that one good gene is enough to have normal function. But when you inherit two copies of those bad genes, one from each parent, then you get the disease. So the chances of getting it from a parent, instead of being 50%, because you need one bad copy from each parent, is 25%. So the risk is lower, but usually recessive diseases oftentimes are more severe diseases than the dominant form. So we say that autosomal dominant polycystic kidney disease is the most common inherited genetic disease in the world, but probably also because it usually doesn't start to manifest symptoms or cause kidney failure until people are older and they're past reproductive age. So age of needing dialysis for that disease are about 50% or 50 years old for the more severe mutations, and even up to 70 for the less severe mutations. So those are people who've had their children, probably didn't know they had it because we only knew about this disease for the last 20, 30 years. Knew much about it. And, they have already passed on that gene, unfortunately. And so, that risk is there. And it doesn't mean half the children have it. It's just every pregnancy, the risk is 50%.
Interesting. And we kind of talked about in general kidney disease and symptoms, but are there symptoms that you would see if you had a DPKD and maybe weren't aware of it before, or you hadn't been diagnosed and
Yeah,
you were
yeah.
having symptoms?
Yeah, so I think this is one that we're diagnosing earlier now,
Mm-hmm.
fortunately, and also because it does, the symptoms are not always specific to PKD, but the most common thing we see is high blood pressure, early high blood pressure. So, and that's as simple as doing an ultrasound in a young person who has high blood pressure to see are there cysts there. As you get older, it's normal to have what we call simple cysts.
Mm-hmm.
You get a few over the decades, but when you're young, you really shouldn't have any. So if you have high blood pressure and have any cysts in your kidneys, even if they're not to the point where they're innumerable and huge and massive, that's unusual and really should be seen by a kidney doctor. So most common way we make the diagnosis is they get high blood pressure and or they had a family history and they're getting screened.
Yeah.
Other than that, they might present with kidney stones, and kidney stones are really common in ADPKD. So they might present more with the symptomatic stones, and then incidentally found on ultrasound, they have polycystic kidneys. And they can, especially when the kidneys have grown quite a bit, have flank pain.
Mm-hmm.
So they might have chronic, back pain or chronic flank pain that leads them to end up diagnosed. Urine infections are another common way that people get recurrent urine infections, or the cysts themselves can get infected. So, kind of those a little bit weird, little different than other chronic kidney disease, because other chronic kidney disease don't necessarily get urine infections, but they can get more of that. So sometimes they present for something totally and then get that diagnosis. Many patients have seen went in for something totally unrelated, got a scan, and then got that diagnosis.
Yeah. Interesting. I mean, I get the same thing kind of with liver cysts sometimes, and that's one of the diseases I have to think about when people do have liver cysts, and they send them to me as well. And I'm like, well, there's other diseases that can cause that. We don't see a whole lot of primary, liver cysts otherwise, but medication wise, I mean, I assume we kind of treat it based like we would CKD in general, with management, but I find it kind of interesting. Tell me a little bit about tolvaptan.
Yeah. So basic management, like for PKD, is blood pressure management is key, right? The ACE inhibitors and the ARBs are the most are their first line treatment. But beyond that, so the only FDA approved medication that we have is a medication called tolvaptan, or brand name Genarcu, and it is it's a V2 receptor antagonist. So to say that in the kidneys, what it does is it blocks the antidiuretic hormone receptor. So meaning that it basically, the effect is that people will just lose a lot of more water in the urine. They'll also become very thirsty and need to drink a lot more water. But how that ties in is because one of the pathways, one of the known pathways for cyst formation is because of this V2 receptor when it gets activated. So if that were the whole story, though, this medication would be a cure. But it's not the whole story. It's just part of the story. So one of the ways we know the cysts grow is in response to activation by that hormone. And it gets a lot more complicated than that, but that's kind of the nuts and bolts of it. And so that's why also we encourage people to drink a lot of water to try to suppress that hormone naturally. You can't do that 24 hours a day, and you can't do it as completely as you can with the medication.
Yeah.
And so, but it is kind of, like general good advice that we give them. So tolvaptan really seems to slow down the progression for people who are at high risk. So not all PKD patients are even going to qualify for it. Just because you have PKD doesn't mean that tolvaptan is necessarily, or Genarcu is going to be of benefit to you. It's kind of like all our other medications. We have to identify high risk people, because those are the ones that we can see like, okay, it's actually slowing the disease down. And so this is going to be usually for high-risk people, especially younger folks. If you have abnormal kidney function, or if your kidneys are really growing in size very quickly, those are the ones we say like they need this intervention, and it should slow down the rate of kidney decline.
Have you seen less people because of this needing to go to dialysis or transplant with ADPKD if they were high risk?
I've been surprised. I've had some patients that they were really declining pretty quickly. And after starting the medication, it is a process. It is a medication that's under REMS monitoring, meaning that we have to routinely monitor labs for monthly for 18 months. It's a lot. But once we get them to the goal dose, or as much as they can tolerate, really had some patients who have kind of we've really seen that progression halting. Now, that doesn't mean that they aren't going to need dialysis or transplant, but it gives us more time. And we always want more time with our native kidneys if we can. Also more time to, if I've seen them kind of late, unfortunately, sometimes people get to me and they're already stage 4. We can still start Genarq if needed, and if it's indicated, if they're eligible. Most people it's going to be indicated, but we can still start it. But that gives us some time to talk about kidney transplant and living donation and what are our options and things like that, and kind of take a little bit of the pressure off of everything. Because that can be a lot coming and knowing it is a progressive kidney disease, and for most people who have the disease, will lead to them needing dialysis in their lifetime. So, and then there are some people who in their natural history wouldn't need dialysis until they're 70. So even if they qualify and they're eligible based on the criteria, maybe Genarq buys them time to never need dialysis. That's all the stuff we're finding out, because this medication it's been less than 10 years that we've been using it in the US.
Interesting. Okay. Well, that's anytime we have a medication that can alter disease progression like that, that's amazing. Is there a resource that you would recommend if people have more questions about polycystic kidney disease, or just in general, if they themselves or a family member is affected by PKD?
Yeah. So the PKD Foundation is a great website, a great foundation. We actually just had our walk for PKD in San Antonio in support of the PKD Foundation, and I think we raised $140,000.
Awesome.
So they're an amazing organization, and they have tons of resources, not just for patients, providers, family members on their website. And they do a great job of connecting people. They recently, in the last couple of years, started sponsoring centers of excellence and partner clinics throughout the country. So one of the things you can do is go onto their website, look for a center of excellence or a partner clinic. In San Antonio, we're a partner clinic. And what that means is that you have, all nephrologists are familiar with PKD, but there's some of us like myself who focus on it. And that's, a little more in tune with what's going on in research, what's going on in clinical development, and really just kind of what's specific to these patients, because they are different than general chronic kidney disease patients. So in fact, there are two medications that are undergoing trials that hopefully should be starting larger trials in next year or so.
Awesome.
That are potential other treatments for PKD. So, and if you want to be considered for those studies, you're probably going to have to be at a center of excellence or partner clinic. That's probably who's going to be enrolling patients. So, but yeah, PKD Foundation, amazing website, great resources. The people are super friendly if you ever reach out. And then they have lots of educational things throughout the year.
Awesome. Well, thank you so much for joining us today, Dr. Garcia-Everett, and helping us understand two complex but very important topics. Hopefully we'll get to have you back again sometime.
Yeah, thanks for having me.
And that wraps up today's episode of the MedEdit podcast.
If you're already following us on social media, reach out at the MedEdit podcast and let us know which medical topics you would like for us to cover on the next episode.
Thank you for listening to the MedEdit podcast. Please click the follow button to be notified when more episodes become available. For more information about this episode and to find out how you can reach Dr. Cari Sorrell and Dr. Jessica Gray, please visit today's show notes. Be sure to follow us on our socials, Facebook, Instagram, and TikTok to stay up to date on all things the MedEdit podcast. The information and content has been made available for informational and educational purposes only and does not constitute a physician-patient relationship. If you need medical advice or help, please contact your personal physician. The views and opinions of the guests do not necessarily reflect the views of Dr. Jessica Gray or Dr. Cari Sorrell. This podcast should not be considered an alternative to medical advice or diagnosis or confirmation of an illness or disease. Please seek help from your personal care practitioner. Thank you for listening, and tune in next time.